Basic glaucoma exam, part of orientation. Um, there are three components of the basic glaucoma exam. The first is IOP measurement that can be done with a number of different instruments such as the Goldmann applanator, the Perkins tonometer, tonal pen readings, Schiot's tonometer, or digital assessment. The next is optic nerve head assessment that can be done via clinical exam or various optic nerve head analyzers. And finally, we want to assess the visual fields, which can be done with Humphrey visual fields, frequency doubling technologies, or manual Goldmann perimetry. The first topic that we're going to focus on in this portion of the lecture is assessment of IOP. Again, IOP can be done with a number of applanating devices, which I have shown here. Applanation can be done with Goldmann tonometry, which is shown in the upper left corner of the images. That's what we frequently see on our slit lamps. Perkins tonometry, which is a Goldmann applanator on a handheld device. Tonal pen is an electronic strain gauge shown in the middle on the left. We oftentimes will use that in clinic as well. The bottom two on the left are really more for historical purposes. We don't use them clinically that much. One is the pneumotonometer on the very bottom left, and in the bottom in the middle is the Schiot's tonometer. Finally, you can assess pressures digitally with your fingers or other instruments or items, but that's not an advisable thing to follow up glaucoma long term. So IOP measurement with the Goldmann or Perkins tonometer is based on the Fick principle. Basically, the applanator prism head is used to indent a small amount of the corneal surface, and the force required to indent this area of cornea is converted into an intraocular pressure. A Goldmann applanation tonometer tip flattens an area of the cornea 3.06 millimeters in diameter, or 9.36 square millimeters in area. This area was chosen for a very specific reason, and that is that the resistance of the cornea to indentation is counterbalanced by the capillary attraction of the tear film to the tonometer head, and so they cancel each other out, theoretically giving a more accurate pressure reading. And of course, this is dependent on a normal corneal thickness, or assumes a normal corneal thickness. The second reason that this size applanation area was chosen was that the IOP in millimeters of mercury is equal to the flattening force in grams multiplied by 10. So it's fairly easy to convert to an intraocular pressure by just taking the reading off of the instrument, multiplying it by 10, which is quite convenient. The Applanation technique is fairly simple. You instill a drop of fluorescein in the eyes. You carefully position the applanator against the cornea, making sure that you have the appropriate height. You rotate the knob on the applanator until the Myers reach the appropriate endpoint, which we'll see in a subsequent video. You then multiply the number on the dial by 10 and record it in the patient chart. Make sure that you clean the tonometer tip. It's one of the ways that infections can be spread throughout the clinic, and again we'll go over appropriate cleaning methods in a short bit. Here I show a video for Goldmann Applanation Technique. It's fairly simple. The drop of fluorescein is instilled in the eye. You then want to line the patient's lateral canthus along the black marks on the slit lamp so they'll be at an appropriate height so you can get the measurement well. You hold the handle on the slit lamp on the backwards position as you push the base forward till you get close to the eye, and then push the base in and fine-tune it with the actual joystick. You rotate the dial on the Goldmann applanator so as to get the appropriate endpoint, and then once you reach that, you record the number in the chart. And again, make sure you clean the tip. Here we have a video showing the appropriate endpoint for the Myers that you actually see as you look through the eyepieces. And again, the appropriate endpoint is seen when you first get the Myers, or when the video first starts, and again at the very end. The Myers should be about this thickness, and you want the Myers to have equal size above and below that horizontal line. Rotate the dial once you have the Myers in good position until the inner edge of the semicircles just touch each other at the midpoint of their excursion during the ocular pulse, and that should be your endpoint. So as you can see, there is some subjectivity to the actual endpoint for the reading, but with careful technique you can get very reproducible numbers, and that's why this is the gold standard for checking pressure. And with practice and good techniques, it's a fairly easy thing to master.